So we invite the first speaker, Dr. Swetha Karicheri, to talk on glaucoma suspects, when and how to move forward. Dr. Swetha, please. We move to Dr. Surabhi Kapoor. She's here and she's presenting on a tumultuous journey on viral uveitis with inflammatory ocular hypertension and neurosensory detachment.
Good morning, everyone. I'm Dr. Surabhi Kapoor, a senior resident working at GMCH Chandigarh. So I'll be presenting. It's not moving.
You can keep the mic closer to you.
So I'll be presenting a case of a 47-year-old male who presented with blurring of vision for 2 months, with headache with occasional pain in the eyes, colored halos. He already had a medical history. He had got a LI 20 days back from Jammu and was started on maximum tolerated medical treatment in view of high pressures. So when we examined the patient, the best corrected vision was 6/6. However, the IOP, even on maximum treatment, was 44 and 46. He had patchy mid-stromal iris atrophy, and we checked the corneal sensations, which were diminished. The fundus examination was within normal limits. However, closed angles were seen in the left eye and one quadrant in the right eye. So the structural and functional imaging were also unremarkable. Keeping in mind the decreased corneal sensation, patchy iris atrophy, we were looking for a viral etiology, and therefore we got a torch serology done. And the patient came out to be IgG rubella and HSV positive. We also sent a AC tab for PCR, however it came out to be negative. So keeping in mind all these, and even on maximum treatment when the pressures were uncontrolled, we first made a diagnosis of viral uveitis associated inflammatory ocular hypertension, and we planned the patient for augmented trabeculectomy with MMC. So on post-op day 1, we had a happy patient, good bleb, no evidence of hypotony. We started the patient on valcyclovir. We did it under the cover of valcyclovir, and we give the routine post-op medications as given to other patients who undergo trap. And then we had a surprise on post-op day 9 when the patient presented to us with a decrease in vision in the left eye. So we got an OCT macula done, and we saw a neurosensory detachment. We studied about it, and we saw that there are very few reports, especially one report with a Sturge Weber syndrome patient who had a neurosensory detachment after trabeculectomy. So we were more likely thinking towards an inflammatory cause. So we just started the patient on tablet prednisolone 1 mg per kg. However, poor patient lost to follow-up for about 6 months, stopped all medications on his own, and later presented to us with fibrinous exudative retinopathy. So this is a picture showing the media clarity of grade 2 with the fibrinous exudative retinopathy on the superior temporal arcade. OCT through the lesion shows signs of fibrinous exudative retinopathy, and OCT through the macula still shows a persisting NSD. We got a FFA done to just confirm our diagnosis, and we saw a leak. So we studied more. We just saw that intravitreal brolucizumab do wonders in these patients. However, only one case study was there, but we took the chance, and post brolucizumab, it was magical. The fibrinous CSCR resolved. No NST seen in the patient. So use of brolucizumab for fibrinous CSCR is not yet widely reported, but it demonstrated remarkable efficacy in our case. And just going by the title report, in patients who have viral uveitis with such high IOPs, so showing signs of inflammatory ocular hypertension, we should start them on tablet valcyclovir, and we should do it under the cover, and we should always be very careful that we can get some extraordinary responses post-treatment as well. Now, what was the USP of our case? It was a bilateral presentation of viral uveitis associated intraocular hypertension. There was a development of fibrinous CSR following an uneventful augmented trabeculectomy for an inflammatory glaucoma, which has not been reported so widely, and the resolution of fibrinous serous retinopathy with a single intravitreal brolucizumab administration. Take-home message: corneal sensations must be evaluated in setting of high IOP with signs suggestive of previous episodes of uveitis. Bilateral IOP should be documented. Chronic inflammation, multiple mechanisms, systemic associations, and unpredictable response to treatment make uveitic glaucoma challenging to manage. Thank you.
Thank you for the presentation. And I have a couple of questions.
Yes.
So you had high IOP in both eyes, right?
Yes,
so, and you initiated treatment with vasectomy and with antivirals, and then took up for
Ma'am,
surgery?
firstly, the patient had this patchy iris stromal atrophy, corneal sensations were decreased. So we were thinking of viral etiology. So we got the torch test done first. Once the IgG rubella and the HSV came out to be positive,
On serology.
yes, ma'am.
Yeah, but this is IgG or IgM?
Ma'am, this was IgG, but we consulted our the infectious physician in our institute, and under his recommendation, he was like that we should start the patient on valsectomy. So
Okay.
it was a collaborative approach between the
Yeah,
infectious physician
Yeah,
and
right.
the
So I have two
ophthalmologist.
questions then.
Yes, ma'am.
Yeah, so did you look for rising or falling titers after a week?
No.
Again? No. Okay. Second question. For how long did you give the antivirals and medical management before taking off the surgery?
Ma'am, before taking, ma'am, in these patients, we have to give it for a prolonged period of
No,
time.
my question is how long did you try medical management before you took up for surgery?
Ma'am, this patient was already on medical treatment for like 1 year. He was already. But you are talking about antivirals.
Glaucoma.
For glaucoma, yes, ma'am, that is what I am saying.
Okay.
So when he was referred to us, he was already on medical treatment for like 1 year. He was on maximum
How many
tolerated.
medications?
4 medications along with 2 oral medications. He was with glycerol and acetazolamide as well. So he
Okay.
was in all these, and still the IOP was not controlled on
Right.
medical.
Second question. So
Yes.
when you took up for surgery, did you send the AC
Yes, ma'am. I
For-
mentioned, yes,
for
ma'am. Yes,
yeah,
ma'am.
and
Yes.
that also showed
Ma'am, that didn't show, but it was
that
not.
was not negative.
Yes,
That
ma'am.
was negative.
But that was negative. Yes.
Right.
Nice presentation. Do you also have CPs to share with us? The iris atrophy and the. And you said it was unilateral iris
Yes,
atrophy.
ma'am. It was more of a. I can say it was more of an iris hole kind of a picture.
So that would have been interesting to see. Do you know something about BD, the bilateral
Yes,
acute
ma'am.
depigmentation
Yes,
of the
yes,
iris?
ma'am. Patients who instill more of fluoroquinolones, hydrofluoroquinolones, they usually present.
And even post-viral can also present like this. So now what is your approach in your center? So do you routinely do AC taps for pictures like Beatty, or do you start with valacyclovir or preemptively, and also on steroids? And another thing, did you notice pigments or cells? Did you notice the difference between pigments and cells?
Yes,
Were they
yes,
actually
ma'am.
cells or
That we-
pigments?
Yes, ma'am. That we looked very carefully
Because
we
with
were-
depigmentation and iris atrophy, there usually are pigments which also resolve with steroids. So that you must see always. Now, what do you do?
Yeah, so one typical thing I would say about the case that you presented is it is not always true to have corneal sensations affected if you have a viral uveitis actually. That is more of a corneal viral involvement. You do not, I mean it is very peculiar that you had a corneal sensation drop. So I'm not sure whether it is related to the viral uveitis per se or anything else. Regarding the treatment of valcyclovir, well, I'm not a uveitis specialist though, but generally we do an AC tap for all patients who have uveitis like picture, whatever surgery we are doing. And based on the PCR only, we start antivirals.
No, ma'am, ours was negative, but we still started the patient.
So you do tracheotomy for both eyes?
No, ma'am. Initially we did it for the one eye, and then later we did for the
So you can actually see trapezius uveitis and CSR with the Beatty kind of picture as one
Okay, ma'am.
spectrum.
Okay, ma'am.
So
Yes, ma'am.
it was an inflammatory etiology, so it would affect anterior segment or rather than differently. So Avastin or the anti-VEGFs can help that also.
Yeah. So there is something called as presumed viral uveitis where you treat empirically with antivirals, and in those situations you do give at least a week of antivirals and steroids before you go ahead with the trap, so that you get less problems with the macular involvement and post-operative inflammatory things is what I would